So good afternoon, everyone. So yeah, as usual, we are gathered here on Wednesday for our usual CME lecture series. So this time we are going to change the gears and we are going to look into some gynecological aspects of our main theme, that is non-communicable diseases. Today's topic will be triad of PCOS, that is polycystic ovarian syndrome. So today we have a very dynamic and young gynecologist from University of Peradeniya, Dr. Champika Gihan. He has got his MBBS, MD, as you all know, and he has got his MRCOJ in 2017. I say that he's young because he has got Young Gynecologist Award in 2017 by Sri Lanka College of Obstetricians, and also he has got an International Young Gynecologist Award, that is in 2019 in the Asia Oceanic region. So he's a young surgeon in the whole of Asia, I suppose, young gynecologist. And he's a very dynamic person. He has come back with loads of knowledge from UK after his training. His main interest is in human fertility, right? So this is part of, I think this is also involving fertility, polycystic ovaries. So he'll be talking to us on this topic today. So I'll call upon Gihan to come and take the podium.
Good morning to you all. Thank you very much, Dr. Arindam for the kind introduction. Today's my topic is PCOS. I'm coming to the term triad. Why I'm using the term triad in my halfway of the lecture. Right. So we'll get on to the topic. Right. So this is the layout of the lecture. I'm discussing the gravity, then the particular syndrome, the spectrum of disorder, and the manifestation, which is the phenotypes of PCOS along the lifespan of humans, and the triad, the diagnosis, the diagnostic criteria latest, and the triad. I'm coming to that entity, but I don't want to describe at this point without the introduction. There will be three dysfunctions in three main systems. So I will be discussing that, then the management and the latest therapeutic agents or the latest management options we have in the world. The gravity, it is the commonest endocrine disturbance in women. Right? I think the endocrinologists will agree with me. This is the commonest endocrine disturbance in women in the world, as well as in Sri Lanka. The prevalence is 8 to 13%. Some research articles, some textbooks goes even up to 20%. On average, I would say 10-12%. Another important thing is 70% of affected women remains undiagnosed. So hidden morbidity. It is the main cause of female subfertility in the world. Not the subfertility as a whole or subfertility in the couple. It is the main cause of subfertility in women. So commonest endocrine disease in the women, commonest the cause for subfertility in women. And now the world is thinking the PCOS in terms of the economic burden to the world, or as a country, the economic burden to a particular country because of long-term sequelae or higher comorbidities associated with PCOS. So that's the gravity. It is proven from the well-known systematic review published in Human Reproduction in 2016. The syndrome, syndrome, we know the definition is heterogeneous collection of symptoms and signs. And here PCOS is a spectrum of disorder from mild to severe. It's a spectrum. A particular woman can be at any point of the particular spectrum. And another thing is, if you take one individual female, the disease severity or the progression may change over the time in her lifespan of the particular female and the particular individual. So it's dynamic. Another important point. So why I am saying this is a spectrum? There is wide, vast clinical manifestation. There are multiple symptoms, and the spectrum of change in serum endocrinology is vast. And it doesn't stop there. There's a late sequelae. At the end, it goes in hand with non-communicable diseases, which I'm coming to describe later. So the spectrum symptoms. Why? Because I'm a gynecologist, I took the menstrual disturbance as the number one. Then obesity, the main concern. Hyperandrogenism and associated symptoms, acne, hirsutism, or excessive hair growth, and male type hair distribution or hair loss, alopecia. Then another common problem to the world at the moment is infertility. 1 in 7 couple in the world is subfertile. 1 in 7 couple. And this is the number one cause for female subfertility. Same time, that particular PCO, particular female with PCO can be asymptomatic. Right? But the disease pathogenesis is continuing inside her body. She is asymptomatic, so no one is able to diagnose unless we do a sort of asymptomatic screening in an asymptomatic woman. The spectrum of endocrinology, again vast, elevated androgens, mainly the free testosterone, and increased luteinizing hormone LH, increased fasting insulin because of insulin resistance associated with PCOS, increased prolactin level, and she is anovulatory because of that. She is lacking progesterone. Because of that, there is unopposed estrogen activity in the body. I am describing each and every later. And there is reduced sex hormone binding globulin synthesis in the liver, which affects the free androgen component, or it increases free androgen index, which has effect on almost all the organs in the body, not only the reproductive system. Spectrum, the another thing is late sequelae. DM, dyslipidemia, hypertension, cardiovascular disease. I haven't included cerebrovascular disease here. These again associated with PCOS, endometrial and malignancies. There are two main concerns: endometrial CA and breast CA, which can be associated with PCOS, and psychological morbidity. The phenotype, there are multiple phenotypes in PCOS. Depending on the age of the particular individual. The expression of PCOS may begin early in the first decade of life. But the etiology happens in intrauterine life. Genetic programming as well as epigenetic programming. So, etiopathogenesis happens intrauterine, manifestation becomes early in first decade of life, and it spreads throughout the lifespan. It extends even up to postmenopausal life till female dies. So from age 0 to the end. Because of varying phenotypes, symptoms and signs changes across the lifespan of the particular individual. So we have opportunity to catch the female at any point. But still it has become a hidden morbidity in female population in the world. So in generally, pre-pubertal and adolescent age group, first and second decade of life, the main concern will be hyperandrogenism and associated complications or manifestations. In 20s, 30s, and 40s, it is reproductive dysfunction, as well as there will be hyperandrogenism. I'm highlighting the main concern in the spectrum depending on the age. Postmenopausal, it is metabolic dysfunction. Or, in other words, malignancies plus NCDs. This is the triad that I was referring to. There's another three coming in PCOS, which is diagnostic criteria. But I am not referring, I am emphasizing, I am not referring to the diagnostic criteria 3 points, but I am referring to the triad as disturbance in reproductive function, endocrine functions, and metabolic functions. Good olden days, we didn't talk PCOS in this aspect. It was mainly, with the gynecologist. Now it is MDT. But I think audience will agree. I have the authority to discuss PCOS because ovarian dysfunction is the central thing. But this is MDT, endocrinologist, physician, the physicians who are looking after the postmenopausal ladies are involved in the MDT. The pathophysiology, obviously, it is multifactorial, as you all are aware. Genetic, epigenetic, and environmental factors are involved. The actual beginning happens in intrauterine life, but after birth, environmental factors play a role for the manifestation of the full-blown syndrome, PCOS, even though the origin is intrauterine, and it is polygenic, complex genetic triad disorder, and there are environmental risk factors. Maybe in utero environment, intrauterine environment, hostile in utero environment, in a growth retarded fetus inside the maternal uterus may play a role for the later life PCOS. And postnatal after birth, like our poor dietary habits, lack of exercises, and sudden weight gain manifest the disease. PCO, not PCOS, polycystic ovaries can exist without clinical signs of the particular spectrum or the syndrome. But our bad habits makes the full-blown syndrome. The PCOS there, the conversion of PCO to PCOS depends on the environmental factors, lack of exercises, diet, weight gain. It becomes a full-blown syndrome. We have to interfere that conversion of PCO to PCOS because we can't change the epigenetics or genetics. She may be born with PCO, but we can prevent the going into full-blown syndrome. Now I have covered diagnostic criteria. A lot of international bodies, organizations are doing the surveillance daily PCOS because it is a main health concern in the world. So ASHRI is European Society of Reproduction and Endocrinology, British Fertility Society, Royal College, WHO, and there's a Center for Research Excellence in PCO. Right? There's a center. So we can understand the gravity. The diagnostic criteria, again, there are 3 criteria, and there should be 2 out of 3 to diagnose PCOS. It is clinical, biochemistry, as well as ultrasonic evidence. Same time, we have to exclude other etiologies for the same presentation, like congenital adrenal hyperplasia, mainly the late onset. Early onset CAH manifests very, very early, maybe even at birth. But late onset CAH, androgen secreting tumors wherever in the body, maybe in ovary, maybe in the adrenals, Cushing syndrome, and thyroid dysfunction and hyperprolactinemia. With the exclusion of those things and presence of 2 out of 3, it is diagnostic of PCOS. Criteria number 1, menstrual irregularity. In other words, what is happening in the body is ovulator dysfunction or anovulation. Irregular cycles more than 35 days or less than 21 days that continue more than 2 years post menarche is suggestive of oligo-ovulation or anovulation. Oligomenorrhea or amenorrhea is the clinical manifestation, but we know it is oligo-ovulation or anovulation. Number 2, clinical or biochemical evidence of hyperandrogenism. Clinical is hirsutism, acne, and alopecia. Visualization is fair. Visualization always excludes the causes that I mentioned, like say androgen secreting tumor, CAH. Because PCOS highly unlikely because visualization. Visualization features are clitoromegally, masculinization, voice changes, irreversible voice changes, breast atrophy, like that. You don't see those things with PCOS. And to assess the hirsutism, there are modified Ferryman-Goldwell charts to assess the terminal hair in 9 body areas of the female. The biochemistry is free testosterone will be the best, but total testosterone, DHEA, and androstenedione again helpful. But we go by the free testosterone because, as I explained, and I'm explaining in my later slides as well, there is a change in sex hormone blinding globulin. So because of that, there's a change in FAI, free androgen index. So we go for free testosterone if we need a biochemistry help to diagnose. Sorry, I forgot to tell the latest guideline is from the Monash University, Australia, 2018. That's what we use at the moment in the world for PCOS. Number 3, we get the use of the ultrasound. Endovaginal or transvaginal scan with 8 MHz frequency. Polycystic ovarian morphology in at least 1 ovary is enough. Either ovary. We don't need to see PCOS morphology in both ovaries. The figure is follicle number more than 20 and or ovarian volume more than 10 cc or more than 10 milliliters. Why there is increase in ovarian volume is cortical thickening, stromal hyperplasia, and there will be multiple arrested immature follicles. They have developed to a certain extent, but they get arrested because of endocrine changes, mainly increasing intra-ovarian androgens. So they don't become mature follicles. Female is anovulatory. There are multiple immature arrested follicles in the periphery of the ovary. Presence of 2 out of 3 is diagnostic of PCOS. There's another 3, that is MDT Triad. Okay, endocrinologist. I took endocrinologist first because it becomes easy for me to describe. Okay, otherwise we are not scared of the endocrinologist. It's easy. For me to build up the lecture, it's easy if I discuss the endocrinological dysfunction, then reproductive, then metabolic dysfunction. Okay. Right. So again, 3 basic MDT team members, but there are a lot more. Nutritionist, blah blah. Right. Endocrine dysfunction in PCOS. It is the main thing is association between insulin resistance, compensatory hyperinsulinemia, and hyperandrogenism. This is the insight into the pathogenesis of PCOS. So, under the endocrine dysfunction, I am discussing these, say, 6, 7 the entities: hyperandrogenism, insulin resistance, ILH, low SHBG, then underpose estrogen, and hyperprolactinemia. Hyperandrogenism, that is mainly because of 2 things. There will be systemic hyperandrogenism as well as intra-ovarian hyperandrogenism. ILH increases the synthesis of androgen by 3% in the ovary. High insulin, which it potentiates the action of LH on 3%, as well as insulin reduces sex hormone binding globulin, which indirectly increases free androgen component. This is the equation for free androgen index. Testosterone multiplied by 100 divided by sex hormone binding globulin concentration. The intra-ovarian androgen excess is responsible for anovulation. I have given the figures here. If it is less than 3.5, it's normal. If it is more than 5, number one thing to exclude should be androgen secreting tumor, and patient should have virilization features. PCOS in between is between 3.5 to 5. There's a printed mistake. It should be nanomole per liter, not moles, nanomoles per liter. The second thing is insulin resistance and hyperinsulinemia. That is because of the resistance, mainly because of post-binding abnormality in insulin receptor mediated signal transduction. It is an intrinsic defect in PCOS. It is independent of obesity. You know, obesity causes high insulin resistance. But in PCOS, the nature of the disease is an intrinsic defect of PCOS, not depending on the obesity. Obesity plays an additive role, right? Because PCOS females majority are obese. So it's combined additive effect is there. And when you see a female, when you ask the history, we know the intermenstrual interval. Some may ovulate once in 2 months. Some may have menstruation 1 in 2 months. Some may have 1 in 6 months. So twice a year. We know it is because we know she is having high degree of insulin resistance because intermenstrual interval correlates with the degree of insulin resistance. And another sign is acanthosis nigricans. Hyperinsulinemia stimulates the trophic changes in the skin. You may see in the back of the neck, under the armpit, the thickened, velvety-like blackish skin. That is acanthosis. Another endocrine dysfunction is increased LH. Increased androgens disrupt the regulation of LH and FSH. It becomes a vicious cycle. LH affects androgen, LH increases androgen synthesis. Now androgen disrupts the LH-FSH balance in the body. Higher the LH, higher the risk of subfertility. And we see high LH mainly in slim or thin PCOS female, which are resistant to treatment. Slim PCOS is nasty in terms of reproductive outcomes. Difficult to make them pregnant. High LH, high androgens, they are slim. So diagnosis may be delayed. Right? No one will suspect because our mentality is obesity is always with PCOS. And another thing is ovarian volume. That's why we calculate ovarian volume in this scan. Is correlated with high LH. So we don't need to do the LH assessment, which may be costly. But we know if the higher the ovarian volume, higher the LH, higher the resistance to treatment. Reduced sex hormone binding globulin, everyone knows this increases the free androgen index. And this is a metabolically active androgen. Hyperestrogenism, actually what happens is unopposed estrogen. Because of anovulation, there is no corpus luteal formation in the ovary. There is no progesterone in the systemic circulation. So unopposed estrogen is bad. Reduce progesterone, anovulation. If we are assessing progesterone in a female to interpret, always we have to do in mid-luteal phase. Right? To interpret, because mid-luteal phase is corpus luteum is there, progesterone is there, she is ovulating. But the problem comes if the female is amenorrheic or oligomenorrheic. Then we time, first we do in mid-luteal phase, suspected mid-luteal phase, and we have to repeat weekly till she gets the menstruation. But if she is actually amenorrheic for a long period. But sometimes it may not make a change in the management because we know the other parameters if we can't time the progesterone, serum progesterone level. Another concern is there is mild hyperprolactinemia associated with PCOS. It again contributes to an ovulation. Number 2 from the triad is reproductive dysfunction. From the endocrine dysfunction, it's easy for me to describe the rest, the metabolic dysfunction and the reproductive dysfunction. Menstrual irregularity, almost I discussed already. It is due to anovulation or oligo-ovulation. Intra-ovarian increase androgens arrest the follicular development. So those are the arrested follicles which we see in the scan in the periphery of the ovary. Longer the intermenstrual outcome, due to the reasons that I explained, poorer the longer the intermenstrual period, poorer the outcome in terms of reproductive functions. Basically, fertility. Subfertility, it is all about anovulation. And here, other than the things that I mentioned already, I am highlighting another thing, AMH. In PCOS, there is higher level of AMH. And AMH again inhibits folliculogenesis by inhibiting the action of FSH on the developing follicle. And why I am highlighting AMH is AMH now world is thinking as a biomarker for PCOS. To assess the risk of developing PCOS as well as to monitor the progress or monitor the response to treatment. If you are doing any hormonal manipulation, if we are doing any intervention to monitor the progress, prognosis. Another thing is recurrent implantation failure and miscarriage associated with PCOS. This is from meta-analysis published in May or June this year. PCOS reduces endometrial receptivity. The implantation and receptivity is a nicely designed program by nature. If there is a minute alteration, it will prevent implantation. And sometimes we don't know that patient is miscarrying because very early, embryo will pass with the next menstruation and patient thinks it is normal menstruation. Say very early implantation happens around day 6-7 of the cycle after the fertilization or ovulation, day 5, day 6, and she is having menstruation on day 14. She had an early embryo which has failed to implant. No one knows that she had the fertilization because she is menstruating on day 14. Unless we do high sensitive HCG assessment by doing a serum sample. This is because of PCOS causes change in microbiome of the endometrium. And another thing which I am discussing later, change in microbiome in the gut. These are the latest thing in PCOS. And there will be subendothelial waves which causes uterine contractions which prevent implantation, again causes implantation failure in PCOS. Progesterone is the one which needed to maintain the pregnancy. And it maintains the uterus in relaxed form. Lack of progesterone causes unwanted uterine contractions or subendothelial waves which prevent embryo getting implanted. Number 3, the metabolic dysfunction. These are the things that I am going to discuss again under the metabolic dysfunction: obesity, diabetes, dyslipidemia, hypertension, and cardiovascular. Obviously, I am not going to into details because that is not my expertise. Obesity. Typical feature of PCOS, but keep in mind there is a slim PCOS entity. And it depends on the ethnicity and geographical area. Champika Gihan is one of the pioneers in PCOS in the world. So this is one of from my study. Done in Colombian suburb as well as in all Sri Lanka as well as in all in the whole South Asia. Obesity in PCOS, it is the concern is your right hand corner everyone likes that obesity. Gynecologist like, non-gynecologist like, and again physician like because of there is gynecoid obesity, or that particular female is having subcutaneous fat. Anyone will not like visceral or android obesity or central obesity because visceral fat is metabolically active. Unfortunately, there is the adiposity that you get in PCOS, central obesity. So visceral fat causes insulin resistance, type 2 diabetes, dyslipidemia, and hypertension. The technical terms are apple shape and pear shape. In all aspects, pear shape obesity is good. Right. Why visceral adiposity is not good? It is an endocrine organ, fat tissue. It exhibits low-grade inflammation and releases pro-inflammatory cytokines. TNF interleukins. I think Prof. Sudhir did a lecture on this in this same podium a few months ago. So again, I'm not going to elaborate. One thing I want to highlight is changes in gut microbiome. It is a new phenomenon associated with obesity. Right? Gut microbiome depends on a diet. High fat diet changes gut microbiome. It changes the permeability of the epithelium. It changes gut hormone synthesis, and it may cause obesity. There is the link, the latest link, the researchers have explained the possible etiopathologist. So I'm repeating, PCOS changes gut microbiome or microbiota as well as endometrial microbiome. Right. Again, to highlight the metabolic effects or metabolic disease risk in PCOS, I took this meta-analysis of publishing Human Reproduction Update last year. Few prospective as well as few retrospective studies, significant number of PCOS patients, and significant duration of follow-up. These are the risk ratios. Hypertension 1.7, type 2, 3, risk ratio 3, total cholesterol 7.1, LDL 3.3, HDL, which is a good one, is minus 2. It's minus. The good HDL is minus. That means if patient is having PCOS, that particular female is not getting the benefits of having a HDL. In a nutshell. And triglycerides 18.5. But yeah, 18.5. But the confidential is wide. Maybe the significance may be bit less, but it is 18.5. Its confidential is bit vast, 0.5 to 37 point. So this describes the gravity. Now my life is easy because of that particular table. Insulin resistance combined with central obesity accounts for the higher prevalence of impaired glucose tolerance, type 2 diabetes. 20% of slim women and 40% of obese women demonstrate IGT. Women with PCOS demonstrate IGT. These are the markers for cardiovascular diseases in PCOS. Triglycerides, LDL, you know. Inflammatory markers, again, relatively old. ACE and ADMA are relatively novel. Advanced glycation end products, asymmetric dimethyl arginine. Not very latest, but relatively novel markers. What will happen to the vasculature or the vessels? Is subclinical vascular disease in PCOS. Increase arterial stiffness, intima media thickness, and I think I did not mention another change is hyperhomocystinemia in PCOS, which predisposes to atherosclerosis in PCOS. Same meta-analysis from last year. Coronary events and cerebrovascular events 1.7 and 1.4 in PCOS. This is from PCOS population. Okay, as I mentioned on the slide, 9 prospective, 14 retrospective studies with significant number of participants. Another morbidity, malignancy. Endometrial hyperplasia, which is a pre-malignant condition, and endometrial malignancy. The incidence is high in PCOS because of obesity, unopposed estrogen, because estrogen is the stimulator for the endometrium, nulliparity, and infertility. All are additive factors. So, as physicians or clinicians, if we can't treat the etiology, mainly because of poor compliance of the female, at least we have the job or the duty to induce her menstruation, at least 4 per year, to prevent thickening and hyperplasia. In a reproductive age, if you see endometrial thickness more than 10 millimeter, we have to induce the menstruation artificially. It's a common drug. Give a 1 week course of progesterone. Right, everyone does. It do the job. It blocks the progression of hyperplasia into malignancy. The best, if you're asking, the best is intrauterine system for to release progesterone. LNGIUS, levonorgestrone releasing intrauterine system, which goes inside the uterus and secrete minute amount of progesterone, levonorgestrone, daily basis. It's licensed for 5 years. The common brand being available in Sri Lanka is Pathophysiology. Another cancer is breast. Lifetime risk of having a breast in a female is maybe 1 in 10. And PCOS increases the risk. Obesity, hyperandrogenism, infertility. If she is not reproducing, she is not breastfeeding, and associated with development of SCA. There's another entity which I haven't included here, ovarian cancer. I purposefully did not include it here because the evidence is controversial. Whether PCOS increases ovarian cancer is controversial. Maybe treatment for PCOS, like multiple ovulation induction, increases risk of ovarian CA, but the world doesn't know whether there's a direct relationship between PCOS with ovarian malignancy. Psychological morbidity. In Peradeniya, we call it heart-rate morbidity. I don't think Candy is aware. Yeah, psychological morbidity. A lot of things for impaired psychological well-being of the female. Impaired health-related quality of life, as I explained, multiple diseases, pathologies. Low self-esteem from obesity, poor body image, hirsutism, acne, alopecia, better for the female. Frustration in attempts to lose weight, because these females are designed genetically to gain weight. It's difficult. even though we are blaming the female, but it is always achievable. Professor will let you. Mood disorders and depression. Then social stigmata in Asian culture with infertility or subfertility. Obstructive sleep apnea and repercussions of that. So all these lead to a psychological morbidity. Management. Second ability, I'm emphasizing. So I would like to discuss the management under these entities or modalities: lifestyle, management of obesity, hyperandrogenism, menstrual irregularity, fertility, and I'm discussing 2 or 3 newer therapeutic agents. Lifestyle. I'm not going to elaborate much more. Healthy lifestyle, healthy eating, regular physical activity. Usual advice is 30 minutes of brisk exercise per day, but to have a sustainable weight loss, the advice is 60 to 96 brisk exercises per day, and obviously calorie restriction. Obesity. Sorry, the title is Non-Fertility Aspects of PCOS, but because any research article or textbook will describe these are non-fertility aspects of PCOS management, but these measures indirectly improve the fertility, definitely. Fertility or chances of getting pregnant, as well as if the female get pregnant, the pregnancy outcome will be improved definitely. That's why I am putting the but. Non-fertility aspects, but definitely indirectly helps fertility and pregnancy outcome. Obesity reduces fertility, increases risk of miscarriage. Congenital anomalies. Now obesity world is discussing in terms of congenital anomalies. Congenital heart disease in the female, in the fetus. Right? Not only the metabolic problem. So teratogenic. Obesity is proven teratogenic agent. And if the female get pregnant, maternal complications, gestational hypertension and gestational diabetes, problem during delivery, maternal, at the end of the day, maternal and fetal morbidity and mortality. So how to manage? We have to emphasize weight loss improves the endocrine profile, ovulation, and healthy pregnancy. Metformin, I think today's sponsor, but unfortunately, yes, say about a decade ago, the world was believing metformin as a therapeutic agent, but now it's a question mark. It is uncertain for the treatment of PCOS, but still we practice. Anti-obesity drugs, Orlistat and sibutramine, centrally acting SNRI, is licensed for BMI more than 30 and bariatric surgery. If BMI is 35, but if the female is having other comorbidities, severe insulin resistance, surgeon will do the GI surgeon may do the bariatric surgery even the BMI is less than 35. Hyperandrogenism and hirsutism, main cosmetic concern of a female. It's a medical therapy and there's a cosmetic therapy as well. So we are doing a job as physician and beauty salons will do the Ramani Fernand will do the rest. Medical therapy is anti-androgens, obviously. Several preparations, several application modes or orals, whatever. And sometimes we may combine with estrogen because estrogen increases the sex hormone binding globule synthesis by the liver, which reduces free androgen or the metabolically active androgens. So we may give anti-androgens as well as we may give estrogens because of the given reason. Every thing is acts on the hair follicle to inhibit ornithine decarboxylase, which reduces terminal hair growth. Then cosmetic or physical therapy. Females in the audience will teach me. Topical retinoids for acne. This is the gynecologist aspect. Menstrual irregularity. If the patient doesn't have fertility wishes, to start with, the best will be the COCP, combined oral contraceptive pills. We are giving estrogen and progesterone. The progesterone, if it is androgen-derived progesterone, progesterone with anti-androgen effect would be the best. Cyproterone, which is the dial, you must have heard, dial contains cyproterone acetate. And drosperinone, in Delcia, Dronis, Jasmine, the brands, it contains drosperinone. These two progestogens have anti-androgenic properties. Right? So don't just give a progesterone, progestogen with the anti-androgenic property. And weight loss, as I emphasized at the beginning, will do the will regularize the cycles. And I'm repeating, endometrial thickness is more than 10 millimeter. We should induce withdrawal bleeding. For a cause of norethistrodone, if she has failed to shed the endometrium, that means maybe a hypoplastic endometrium. You should have a very low threshold to do a sampling. Sampling is very easy, right? OBD procedure, do a pipal sample. You thought of dose position, specular, pipal biopsy, send to histology. It's nothing. Maybe 2 minutes, 3 minutes. Arrangement of fertility. Always do not start treatment for a female, even though her priority is that, unless the female is optimized. Right? At least to a certain extent, because we are asking for trouble. Disco miscarriage is there, congenital malformation, pregnancy-related complication, delivery complication, postpartum complication, even up to PPH, obesity is a risk factor. And our target should be unifollicular ovulation, minimizing the OHSS and multiple pregnancies, which is on the rise. Multiple pregnancies on the rise in the world. One main concern in treating PCOS is we can't predict the response to ovulation induction. Unlike other causes for ovulation, it is very difficult. It's trial and error. We may start with low dose. We'll do the follicular tracking, no follicle development, but patient has to understand. But thing is, our female do the medical shopping. Even if we don't counsel properly, it is, we have to, the patient as well as clinician should have the patience. Both have to see in a prognostic way. Because it is trial and error. We can't predict the response. If we are treating too much, high stimulation and multiple pregnancy. Again, asking for trouble. So agents are that we are using clomiphene citrate, but not the best. Aromatase inhibitors now becoming the first line, or it has become the first line, number one first line treatment option. Then gonadotropins, FSH, and surgical laparoscopic ovarian ready. Clomiphene citrate was the first line, but it is a SERM, selective estrogen receptor modulator. It's a modulator, not agonist or antagonist. So modulator, some tissues it has agonist effect, some tissues it has antagonist effect. It has an antagonist or anti-estrogenic properties on the endometrium and cervix, which is not good for implantation and at the end of the day for fertility. So clomiphene is sort of vanishing. So it is not the first line now. Letrozole, which is invented for postmenopausal estrogen receptor positive breast malignancy, now we have borrowed from the surgeons. It is the first line for ovulation induction in PCOS. At least in PCOS, that is the first line. It is aromatase inhibitor. There is no anti-estrogenic effect on the endometrium or the cervix. And higher live weight LBR is live birth rate and less multiple pregnancy rate. Second line would be the FSH or human menopausal gonadotropins. And insulin sensitizing agents, metformin has a role in ovulation induction as a second line agent. And weight reduction again second line option, management option. In metformin as alone, if there is no place for ovulation induction, but as a combination, letrozole with metformin will do the job. But metformin alone, there is no place. It's clear now. Then, at last, if patient is not responding, there are indications for laparoscopic ovarian drilling. Fail to ovulate with oral agents, hyperstimulation to treatment, oral or parenteral FSH, hypersecretion of LH, and if patient says, I can't come for the follow-up. If you are giving FSH, patient should have good compliance. If patient is far away or patient is not able to follow up financial reasons, do the laparoscopic ovarian drilling. But keep in mind, there is peri-ovarian adhesion formation and reduction in ovarian reserve because of thermal damage. We do it with minimal thermal damage, 40 watts, 4 punches, 4 seconds. It's 40 watts in the diatherm machine, 4 punches per ovary, 4 seconds. The puncturing time is 4 seconds. But it has a very good role in slim PCOS with high LH. And another beauty is effects last 4 months. If you are giving letrozole, that is only for this cycle, particular cycle. Laparoscopic ovarian drilling may last even up to 1 year. The last resort is IVF, but not the first. Definitely, I am repeating, not the first. If there is another reason for subfertility, like tubal factor, or if patient has failed to conceive despite of ovulation, multiple ovulation, at least for 6-9 cycles, then go for IVF, but not the first line. Last 2 or 3 slides, new agents. Inositols is in the market, several brands. Physicians, there are role in medicine as well, general medicine. Inositol and G-inositol is variable efficacy in improving insulin resistance. GLP-1, glucagon-like peptide receptor agonist, again, is to reduce the cardiovascular events and reduce the incidence of type 2 diabetes. And it will improve the metabolic outcome in PCOS. However, now evidence again from the last year publication, it is now superior to metformin. GLP. This is ours. Ceylon cinnamon. We export other countries by Ceylon cinnamon. You know, Ceylon cinnamon is not available in other countries. I think there are in African countries there, and another subtype of cinnamon. They get the product from us. They make the powder and sell to the whole world. Anti-inflammatory, antioxidant, anti-diabetic, antimicrobial, and it has cardiovascular protection. The original studies from Sri Lanka, that's not a thing at all. Improves insulin sensitivity in PCOS. Improves lipid profile. Increases the chances of ovulation, and it has a now it's proven overall benefit in PCOS. We have started in Peradeniya, big RCT, double blind. One of MPhil student is doing underneath. Therapeutic effects of Ceylon cinnamon in PCOS. I am requesting from you all, if you have patients, refer to us. If patient is willing, can participate in the study. We are assessing if therapeutic effects of multiple effects, multiple sub-objectives are there. in achieving ovulation, fertility, and pregnancy outcomes as well. Okay, thank you for your patience, and I would like to take any question. Yeah. Yeah.
At the genetic level, but until the menarche, nobody is suspected or nobody is trying to intervene. Since there are no manifestations, are we to wait till then or to suspect it early and do possible interventions? In the sort of 3 minutes
Pre-menarche. Yeah, good question. Yes, we can suspect like features of hyperandrogenism. I would say that should be the manifestation. But hyperandrogenism, we must have seen, say, grade 3, 4, 5 girls, obese, hirsute, acne, and acanthosis, right? But we can diagnose because we can diagnose using the same criteria, 2 out of 3. But the question is how to treat, right? Definitely, we can't use cyclical combined oral contraceptive pills because she's pre-menarche. But there's a place for anti-androgens, right? There's a place for insulin, to address the insulin resistance and other things. We can diagnose. The short answer to the question is yes, we can diagnose, but therapeutic interventions may be limited. There are, but may be limited. We don't have full options, just like we are discussing for a female in reproductive age.
Even the criteria is something like 2/2.
Yeah.
2/2, because menarche is not a factor. Menstruation is not an issue during that time.
Yeah.
So other than
I want to add, we can do a transabdominal scan. Yeah. Even though the guideline says the transvaginal, yes, we diagnose. I would say we see a lot of polycystic ovaries from a good transabdominal scan machine. Yeah, sorry, I disturbed your question.
Still, I mean, we can do other possible lifestyle modifications and interventions. We're not going to do more relaxation. Is it a standard treatment or something standard?
Yes, because we have to address childhood say. We can't say child. Can we say child? Yeah, we can say childhood obesity. Yes, we have to interfere there. Because at that point, we know even though she has not manifested fully, she is carrying her genes and epigenetics. And if you see that because these girls are coming with the mother is full-blown PCOS. Right. So we know she is on the path. We can't reverse that, but we can't block that, or we can't delay the progression, or we can block the progression, or we can delay the conversion PCO into full-blown PCOS by early interventions. Starting from simple lifestyle. Diet, yes, it is area multidisciplinary. Refer to the nutritionist. Early. Exercises. Then only the drugs comes. Yeah, very good point to interfere at that, say, second decade of life, or even first decade of life. Am I answering the question? We see now, on the road we see obese girls and going with obese mother. So we should have a cartoon, our picture should be full-blown metabolic syndrome. Not a fat chubby girl. And another common scenario that will be daily experiences. Chubby neonates. Mothers are happy, nurses love we see at the end of the day it's a full-blown package. In her, all the manifestation will be early in her second, third, fourth decade of life with the all non-communicable non-communicable disease package. Because genetic programming is happening. So life is now, we are discussing the first 1,000 days of life, starting from the fertilization. Day 1 is fertilization. And first 1,000 days of life is crucial, which includes intrauterine life. Genetic programming happens there. Both obese or macrosomic babies as well as IUGR babies. Both are bad.
Is there a difference in the prevalence of in the Western countries and in Asian countries? Because we see this childhood obesity, it has come now. Those days we didn't have any childhood obesity. Now we see the childhood obesity and we take it as a disease component. But is there a difference? Because that, of course, maybe in matter of factors. Is there a difference of PCOS in the Western countries and the Asian countries? Prevalence is the same.
Yeah, I think that yeah.
No,
When I'm making good question. When I'm making the presentation, I thought of including, but at the end I have forgotten. There is one study, very nice study, from a UK research Oxford team, I think. Yes, definitely Asian population at high risk of PCOS and metabolic component, and they are very resistant to treatment. High insulin resistance there. So reproductive outcomes, even outcomes after IVF for PCOS couples or PCOS ladies, outcome is poor in Asian population. And then they have analyzed the subcohort, UK, there are Asian, India and Bangladesh in London. So Asian population in UK, they are very resistant treatment, high prevalence, even though they were born in that particular sibling or particular individual is born in London, UK. Parents are from India or Sri Lanka, high prevalence, high resistant treatment. Nice study. So sorry, I could not include that. So higher prevalence in Asia, South Asia, and high resistant treatment, poor outcome in Asian population. Any other question? Yep.
Engaging in high intensity sports in the adolescent period. The protective effect of is there a relationship between that and PCOS?
Question goes to sorry, I don't know the answer, to be frank. Sports medicine. I hello. Sorry, I genuinely I don't know the answer. Repeat.
The question is, adolescent girls engaging in high intensity exercises or sports during their adolescence, does that have a relationship with PCOS? For example, early manifestation of PCOS or the progression of it?
I haven't heard, I haven't read. Hey, I don't know.
I also haven't heard about the
Why are you asking that? Why are you asking? Any thing that you have experienced?
As I said, lifetime modifications are important and exercise is one aspect.
Yeah.
So now when we encourage our children, especially girls, to engage in sports, do we restrict them to kind of casual exercises here and there, or else is there a risk of are we putting them at risk of early manifestation of PCOS? For example, because in athletes there's a female athletes there's a trial for the female athlete trial, which includes one component is amenorrhea. So I wanted to know.
Alright, okay, got the point. No, that is not. Yeah, now I got the point. The question is, yes, there is say Olympic athletes, they may be amenorrheic, right? Yeah, actually Sugantika had the problem, right? That is weight related, or it is mediated at the hypothalamus level, right? Here PCOS is another HPO dysfunction, which is separate from hypothalamic amenorrhea. But again, at the end, all say excessive weight loss, Olympic athlete, hypothalamic amenorrhea, again it's HPO dysfunction. But this PCOS HPO dysfunction, which happens in PCOS, is different from that amenorrhea. So anorexia nervosa, bulimia nervosa, excessive sudden weight loss. Excessive sudden weight loss, that is leptin mediated hypothalamus level is different. Yeah, both are amenorrheic or oligomenoric, that particular PCOS as well as Olympic athlete, but two different mechanisms of HPO dysfunction because of the two different mechanisms of anovulation. Any more?
Thank you very much, Dr. Gihan. It was a very wonderful lecture and very comprehensive and scientific, and also the discussion was very enthusiastic. Thank you very much for the participants who actively participate for the discussion. And so this is go hand in hand with the KSM this year topic of non-communicable disease. And in terms of non-communicable disease, we can see now the PCOS is also play a major role. Thank you very much, Gihan. And I cordially invite Dr. Arvind Dharmapal, the Senior Consultant Surgeon, to hand over Certificate of Appreciation to Dr. Gihan. Thank you very much for the participant and announcement. 30th, we have the last week also we mentioned it. We have a stroke workshop which is organized by WHOA and Sri Lanka SLMA, which is a very good certificate course, and given a very newly paid for 1,000 for participation. And I think we have very few slots available, 5 or 8. If you can give a call to Duranjali, you can reserve your place. And thank you very much for all the participants and online participants. And special thanks goes to the our sponsor, Merck. And thank you very much for sponsoring us. You are doing a great help for us to continue CME lectures, KSM lectures, and the refreshment will be provided in this. Thank you very much.